Hi, this is Brian Kim. I'm going to share with you case number 43 in the best way to do cataract surgery series. This is a soft lens, and this is not just a small pupil, this is a really tiny pupil. I'm going to show you systematic lens disassembly using double chop, cross chop, mechanical fracturing techniques, pulling lens pieces up out of the bag using the chopper, using the phaco tip as a second chopper to help me manipulate the lens and crush the lens pieces. I want you to really appreciate how small this pupil is and how it seems to pulse in the middle of my lens removal. So I'm going to use a cotton tip to help center the eye, and then I'm using a corneal marker to help me center and size my rhexis. I'm using a cotton tip to turn the eye upward, which is to the left. This patient is resisting me a little bit. I'm encouraging to look up. I'm making my paracentesis incision, making sure I'm flat to the iris plane. And then I go on the other side and do the same thing. Again, this patient's resisting me quite a bit as I'm trying to manipulate her eye, making a flat approach. This allows me to make a self-sealing corneal incision by creating a nice corneal shelf. I'm injecting some intracameral lidocaine and then now some intracameral epinephrine. I'm trying to paint the epinephrine along the entire iris surface, but as you can tell, the epinephrine did very little to make the pupil big. Hopefully it stabilized the pupil to some extent. So I'm injecting some dispersive viscoelastic to fill up the anterior chamber as well as coat the corneal endothelium. You see me, I'm moving the eye with the cannula and I'm encouraging her to loosen the eye so I can manipulate it a little bit better, and that was why I wiggled that cannula. I'm turning the cannula away from me. I'm making the triplanar corneal incision. I make a vertical groove, tunnel into the deep part of the groove, into the cornea, and then go in, and that's a triplanar corneal incision. This is my puncture style Capsulorhexis technique. I puncture and then pull down towards me. You can see that the pupil is quite small, but I can try to make the rhexis a little bit larger than this because my marks are outside of the pupil edge here. And so that's why you can see I'm trying to make it a little bit outward, a little bit larger than the pupil edge here with the rhexis. The nice thing about this is I don't have to worry about radializing the rhexis, but I just have to make sure I don't make the rhexis too small with this. All right, finally get the rhexis done, burp some viscoelastic out of the eye, and this is the Capsulorhexis Hydra dissection technique. I'm placing the cannula out to the contralateral equator, making sure I'm in the bag, turn it down, get a nice fluid wave right there. Turn the cannula tip up, make sure it's flat, decompress on the left side, sweep a little bit underneath the anterior capsule edge, go to the right side now, going down with the tip, burying it a little bit as I dial the lens, and you can see the lens is spinning very nicely here. So I'm going to begin the phaco. I activate some of that irrigation fluid, and then I go in with irrigation off, lifting the incision with the chopper. This minimizes any trauma. And I want to carefully try to remove any surface epinuclear material, making sure I don't snag the iris. I go out underneath the anterior capsulorhexis edge with the chopper. I turn the phaco tip vertically, subincisionally, and I'm able to crush the lens and bisect it completely in half with a double chop maneuver. I'm placing the chopper across the right heminucleus, pulling it centrally towards the phaco tip and crushing the right heminucleus, and that is the cross chop maneuver. Again, because the visibility is poor, I'm going to use the chopper as my primary instrument of action. I placed that chopper out and then crushed it and divided that first quadrant. Look at this pupil bouncing around like crazy. It's amazing how unstable that pupil is. I pull the second quadrant up with the chopper and then crush it against the phaco tip. and now I'm emulsifying the lens pieces there. I want to put the chopper out and prolapse that second piece of that second quadrant up, and then I'm emulsifying that piece. So 2 quadrants are out now. I'm going to be able to rotate the second heminucleus in front of me, placing the chopper out to the equator, pulling it towards the ficotip. The ficotip's deep in the bag, bisecting that second heminucleus. First, I try to use a little bit of vacuum, but that didn't work, so I'll go ahead and use a chopper again, pulling that third quadrant up out of the bag and then crushing it with the ficotip, and then trying to emulsify very carefully, keeping that ficotip in the central safe zone away from the iris. This is the fourth quadrant, turning it a little bit and then placing the chopper around the lens material. I go again, making sure I'm definitely around, not on top of the lens. I was able to pull the lens piece up and then crush it against the ficotip, and then very carefully emulsifying the lens piece, making sure that the ficotip is right in the middle, away from the iris. Remember, if you're doing other techniques where you really depend on visualization, people can get really intimidated and scared, and they really think this is dangerous for some reason, and that's because they're looking at the technique based upon their own technique. And so, of course, when you do a technique that's very visual dependent and you try to do this surgery, you might have problems. But if you think outside the box, outside of your own personal technique, and you employ these principles on how I pull pieces up out of the bag, I use a chopper to feed the ficotip the lens material, and the ficotip's really in the middle. And so there's very little risk that you can have when you're doing the technique this way. I'm very careful, I'm methodical, staying away from the iris with the ficotip. You don't need a ring or hooks when you're doing this technique. I think if you're willing to stretch yourself as a surgeon and try to learn these techniques, that's when you really appreciate how powerful and much more versatile you'll become as a surgeon. There was a piece of lens material at the incision, so I take the chopper out, push BSS in with the cannula, take the ficotip out, and then switch it with the INA handpiece. There's a little bit of retraction of the sleeve, and so I'm just turning the sleeve, making sure it's right against the polymer tip there. I go bevel down and I'm sweeping side to side. I'm trying to grasp the cortex on the anterior side near the rhexis edge, and as I sweep side to side, I'm able to get bigger chunks of it, which you can tell with the occlusion. And then now I'm going to the right side, trying to do the same thing, going across from me now and then to the left. Again, when the pupil is small, I like to switch to the polish mode early. I can polish underneath the anterior capsule with a lot of confidence, making sure I can get the cortex very gently without accidentally snagging the anterior capsule. That could happen if I use high vacuum and aspiration. After I polish underneath the anterior capsule, I'm polishing the posterior capsule as well. The polymer tip is extremely safe with this, and I have never ruptured the posterior capsule with polishing with the polymer tip. I go ahead and inject some cohesive viscoelastic, and then I inject some viscoelastic to push the iris back at the level of the incision, because when I go in with the lens, I don't want the iris to potentially come out. So I go ahead and inject the single piece acrylic intraocular lens into the capsular bag. I'm going in with the INA as well as my Maltzman. I'm going to make sure I retract the pupil edge with the Maltzman to ensure that the entire lens is within the bag and to make sure that the haptics are freed from the optic. I go underneath the lens with the INA handpiece, and I'm rotating the lens 90 degrees, and I make sure I evacuate all the viscoelastic from within the bag. You can see as I tilt it, the lens doesn't shift sideways, and so that tells me that both haptics are very likely in the bag, and indeed it was, as I saw with the Maltzman retracting the pupil edge. Once the bag is clean and I make sure that both haptics are in the bag, I remove the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a very, very small pupil. You can see very confident, systematic lens disassembly. I've seen people take cataracts out through small pupils and they really struggle and they're kind of bumbling around. They're able to get through it, but it's really not very efficient. This is efficient, systematic lens disassembly using double chop, cross chop, pulling lens pieces up out of the bag. Because I have that very safe tipped but long chopper, it's very versatile. Again, with sculpting techniques, vertical chop, even horizontal chop, if you're having to hold the lens piece with the high suction with that technique, the soft lens will fall apart. And so I really feel this is such an advantage doing lens disassembly like this with a soft lens and small pupil. So I hope this was helpful to you, and I thank you for your attention.